All right. Hi, everyone. Good evening. Welcome to CSOMA's evening webinar series. We're going to start in about 1 minute. We have a great program scheduled for you tonight. So glad you're here. Ben Zappin, I am going to go ahead and invite you to come on. I'm going to promote you to be a panelist. So if you would accept that so that you can go ahead and say hi to everyone in a minute once we start. Great. Ben's all ready. Yay, so glad you're here. So Ben, I'm
Hi.
just gonna say hi to everyone and start it, and then we'll turn it over to you, and then we'll turn over to Julie and Dr. Bhatti. So you have about 5 minutes in just a second. I'm gonna go ahead and start. So we have about 30 people in attendance right now. We have a lot registered, close to 80 registered. We'll see who actually makes it on a Tuesday night. I know we all have our best intentions and then life happens. But good evening, everyone. I am Ra Adcock, the Executive Director of CSOMA and licensed acupuncturist. I'm the Director of Integrative Medicine for Pediatrics for UCSF. So that's my clinical work. And CSOMA is my great passion and love. So I hope all of you here in the CSOMA community are signed up for our newsletter. If you're not, please go ahead and sign up at csomaonline.org. Make sure you're getting our newsletter and go ahead and follow us on Instagram because there's all kinds of giveaways, prizes, raffles, information about the profession, lobby day, classes, conferences, updates that you need to know, legislative and advocacy actions that we need the profession to take to advance and protect our profession. If you're not signed up for our newsletter, you may not be getting all that important information. So take a minute now, open another window, and go to csomaonline.org and sign up for our newsletter. Tonight, we welcome we were going to do this conference live, and that date wasn't not working in August, so we moved our conference to be online. So we have a webinar series each month on a Tuesday night. Go ahead and go to CSOMA Online and sign up for all of these amazing classes. Tonight, we're so excited to welcome Dr. Bhatti in a few minutes. So to get started, though, we have one of our incredible industry partners here, Ben Zappin from Five Flavors Herbs, who is just such a huge resource, especially for the Bay Area. Five Flavors was the go-to, and now with their online dispensary, they have incredible services. So we're so excited to welcome Ben Zappin, licensed acupuncturist, here to talk about Five Flavors at the end of tonight's webinar. Ben and his team at Five Flavors have given a $250 prize to someone who is here in the audience tonight and who stays through this. At the end, we will do a raffle, and you will get an email tomorrow from all the participants that stay through this class. Your name will be entered into a raffle, and we will announce the winner tomorrow who wins this amazing prize for Five Flavors Herbs. So Ben, I'm going to turn it over to you to give us a talk for, maybe 4 or 5 minutes at most about Five Flavors Herbs and the incredible resources that you offer to our community. Thank you so much for being here. I'll turn it over to you.
Hey, thank you, Ra, and thank you for the CSOMA team for inviting me and for organizing this. And I really appreciate that you kept the momentum, kept the balls in the air with this conference that you initiated, and appreciate the ongoing service to our community. Uh, I don't, I don't think there's any other organizing principle in California like CSOMA. So we're really thankful for your presence, and I know that it's a labor of love for many of you. So we're glad to contribute and glad to be part of uh, not just the industry but the community. We ran a community herb shop in Oakland for a decade. Before that, we ran a smaller herbal pharmacy in Santa Cruz for a few years, and so we're very connected to Bay Area herbal culture, both Western and Chinese herbalism. I've been focused on studying the intersection of Western and Chinese herbs for 30 years. This month is when I really started formally studying. Um, and so celebrating that milestone in a variety of ways. We moved our manufacturing facility to the Sierra foothills in Grass Valley. We live in Nevada City, and we still maintain an online herbal pharmacy that we invite everybody who's here who is um, not already signed up, not already using it, to source granulated extracts, to source liquid extracts that we manufacture. We manufacture dozens of traditional Chinese formulas, single Chinese herbs, and single Western herbs available for formulation and dispensing, drop shipping to your patients. We just added a new feature that went live this month that we're really excited about. We've had um, an ability to make smaller amounts of your custom wholesale formula. So if you wanted to modify a version of Siwu Tang or Guizhi Tang or Xiaochaihu Tang and or Gui Pi Tang, you want to modify Gui Pi Tang with a couple of your favorite Chinese and Western herbs to help it impact the mood more, or to or you're using that and you're studying functional medicine and want to modify it with some herbs that you learn about from a functional medicine perspective, have it in your clinic to dispense to your patients. We've enabled that process online through our online dispensary to make that a much easier process. So check that out. Sign up for an account. Somebody can schedule a time to talk and walk you through it, make it easy for you. Um, so we have our pharmacy. We also have our proprietary formulas, which we've been vending for over 20 years now, which are mixtures of Western and Chinese herbs. And those might be a fun thing for you to try if you win our raffle. Um, they're great things to dispense out of your clinic. They're very popular. And the principles we've formulated them on are the intersection of TCM formulas, and we modified them with Western herbs to amplify the immediacy of effectiveness of the formulas for benefiting the mood, benefiting the respiratory system, benefiting digestion, aiding in sleep, and think we built out some things that are more efficiently effective than some of their Chinese counterparts on which they're based. Check those out. Sign up for a wholesale account. We'll send you information. Schedule with me, and I'll talk you through some of my favorite products. And then the other thing that we do is um, contract manufacturing. About half of our business is contract manufacturing. So if you have a vision, if you have a dream, and there's something that you want to build out and make for your patient base, or you want to start a side business, or know somebody who is, we are, actively engaging in conversations with practitioners and dreamers who are looking to launch brands of liquid extracts on a regular basis. We manufacture for some pretty large dietary supplement companies and have earned the trust of their quality control departments. We had our first FDA inspection last week, so that was another milestone for us. Um, every legal dietary supplement company that you work with uh, needs to be registered with the FDA, every manufacturing company. And part of what comes with that is at some point they'll come visit you and not tell you when they're going to show up. So they showed up last week, and they really liked what they saw. We didn't have any formal things to modify or adjust. We certainly didn't get any warnings. So we're feeling really good about what we're doing. And one of the biggest things that gives me the juice that I have is working with practitioners. So the other feature that I can't not mention is what was formerly Conceivable Proline is now Proline, which is a very coherent, founded by Kirsten Karchmer, one of the early presidents of ABORM, fertility system. And we work with probably 150 fertility-focused practitioners who are using our Proline system to as one of the main delivery systems, one of the main therapeutic treatments for supporting fertility. We get great feedback about it. We have a lot of free supportive educational material. Uh, and we're definitely 2026, we're queuing up some more in-house and probably field study education, probably a couple courses on herb drug interactions that my wife, Dr. Ingrid Bauer, who's an internist, medical doctor, she and I love to teach about that topic together. So stay in touch with us. We want to be in touch with you. We love serving the TCM community, being part of it. And thank you again, Ra. Thank you, Julie. Thank you, Kim. Uh, I'm probably going to, I hope I can get a recording of this because I'm going to go enjoy a meal with my family.
Great. Ben, thank you so much for being here. Your longstanding support of the profession, our communities, CSOMA especially. Thank you for your membership in CSOMA. I put 5 flavors into the chat. So please go ahead, click on. I am a user for myself, my family, as well as patients. I love that anytime I order something, if something's missing, your staff calls me up and once in a while says, we're out of this herb. You know, it only happens once in a while, right? And they're like, you wanted to modify it with this. Here's some recommendations. What can we do for you? Like just the best customer service. If anything happens, they're just always wonderful. So please go and check out 5 Flavors. There's an amazing education series that they offer, that Ben and Ingrid offer. So huge resource. Make sure you're tied in. And someone in this audience is going to get a very generous $250 gift certificate to start or continue your 5 Flavors herbs exploration. So Ben, have a nice dinner. We'll be back in touch with you with that winner sometime tomorrow. Thanks again for
Appreciate it.
being here and all your ongoing support.
Yeah, you're welcome. Thanks, everybody.
All right, I'm going to turn this over. I'm going to put one quick thing into the chat, which is csomaonline.org. This CSOMA is like NPR, you guys. You can tune in. Everyone benefits from NPR. Everyone benefits from CSOMA's work, but not everyone supports it. Without your support, this organization doesn't keep going. We participate in advocacy, lobby days. Dry needling is an issue that we're going to be dealing with this fall and this winter in our legislative session. Without your membership and support, we cannot function and protect this profession and continue to support the schools and all the new practitioners and existing ones. So please consider joining CSOMA at one level or another. Your information to receive credit for tonight's class was in your registration confirmation email. If you have paid for credit for this class, there are directions about how to go ahead and take that certificate for your completion of this class. If you did not pay for it, you're not eligible for that class participation, but you are here to get the benefit of tonight's amazing class. So any questions, email either Kim at CSOMA Online, Ra at csomaonline.org, or info, which is probably the best place to put it, info at csomaonline.org. But please do check your confirmation email first for directions about how to handle everything with tonight's class and your CE certificate. With that, I turn it over to our president and board chair, Dr. Julie Tran. Julie, on to you. Thanks for being here.
Hi, good evening, everyone. Thanks for joining us. I'm just going to get started on the intro because I have the great honor and privilege of introducing my colleague and good friend, Dr. Surya Bhatti, chiropractor, CFMC. CFMC is a board-certified chiropractor trained at Palmer College of Chiropractic with a postgraduate certification as a certified functional medicine clinician. Wow. Try to say that 10 times fast. From the Caribbean Institute, with over 9 years of education and clinical training, Dr. Bhatti specializes in holistic, patient-centered care for individuals with complex and chronic health conditions. His clinical expertise includes addressing autoimmune disorders, gastrointestinal and neurological imbalances, skin concerns, food sensitivities, chronic fatigue, chronic pain, and general wellness. Dr. Bhatti is deeply committed to empowering patients through education, guiding them to implement lifestyle modification, optimize their environment, adopt targeted dietary strategies, utilize professional-grade nutraceuticals, and benefit from evidence-based chiropractic care. Without further ado, I give you Dr. Surya Bhatti.
Good evening, everyone. I'm so glad to be able to present to all of you. I hope you guys can see my screen properly. Yes, sweet.
Yes, we can. And when you're ready, yeah, exactly. Just go into slideshow mode. Perfect.
Awesome. Thank you so much. So today we'll be talking about analyzing blood work through a functional medicine lens. Alrighty, a little bit about me. I am a chiropractor, and it's a privilege to be able to talk with fellow acupuncturists. I really value the care you guys provide to the community, and I just love working with you all. Special thanks to my own teacher, Dr. Datiz Karazian, who has allowed me to use some of his material. He has trained me all these years. My friend Linda Clark is a nutritionist. She has helped me a lot in making everything that Dr. Karazian has taught me and how to apply that clinically. And of course, thank you, Dr. Julie Tran, for having me, and CSOMA as well. Uh, just so that you guys know what I know, I might know what I'm talking about. I have done all these courses over the last few years. I've taken tons of functional medicine courses, even when I was in college. And this is how I built my practice and my knowledge base, and I've enjoyed that thoroughly. And I am a certified functional medicine clinician through Krasian Institute. A little bit fun facts about me. I love to play an instrument called the sitar, and I love to meditate. I love eating savory food. I will always select salt over sweet. Currently, I'm enjoying CrossFit, and my life goal is to merge with the universe or become enlightened at some point. A little disclaimer, this is for educational purposes only. They do not represent, the material presented does not represent any professional institute or anything. And the material presented is not for medical purposes. And it does not replace any independent professional judgment. What we would talk about is general information. I call myself a functional medicine specialist, but I'm more of a generalist. So I may know answers to some of your questions, but not all. So please keep that in mind. A quick overview of what we will be talking about today is anemia patterns for about an hour, and then we'll take a little Q&A for 5-10 minutes. Then you will deserve your break. And then we'll talk about glycemia and thyroid patterns. And if we have some time, we'll do a little bit more Q&A and some feedback for me. And without further ado, here are some course objectives we'll be going over. So we'll be talking about some key points with anemia, blood sugar, and thyroid dysfunctions, which ICD-10 codes you should include, and which are reimbursable by insurance. So it would be a good idea for everyone to know some of those coding. And how to really distinguish functions from pathology, because our lab ranges are so wide. How do we really look at labs with a functional medicine perspective? And of course, some of my clinical experience and how I use all of this knowledge in my practice and what I have learned so far from those. So topic number one, part one, we'll be going over anemia. Anemia is basically when body does not have enough healthy red blood cells, and there's a reduced hemoglobin to carry oxygen throughout the body tissue. When that happens, you will have lots of different types of symptoms, such as, fatigue, dizziness, fainting, pale skin, loss of hair, pale nails. You will see tongue inflammation in certain people. And lots of other things may be happening as well. And this is more prevalent in vegans and vegetarians, and tends to be more prevalent in females than in males, for obvious reasons, because females have menstruation, so they're always losing iron every month. So you have to replenish that. Whereas for men, unless they are bleeding, they won't be losing enough iron to cause them very many symptoms. Though men are more likely to have iron overload, so that's something we have to be careful with. Okay. And this is, I guess, more applicable to acupuncturists, where you guys analyze the tongue, and there's a tongue can tell you a whole deal about it. So when there is an iron deficiency anemia, you may see like a beefy, smooth tongue. And I have learned from acupuncture friends that you guys really look at the tongue and you try to see the marking or indentations on the tongue to classify that as a spleen deficiency or blood deficiency. So sometimes when I see that on my patients and my patient isn't improving, that's a referral for an acupuncturist in my practice. And if there's ever a B12 deficiency, you will see smooth tongue as well, and a little bit redness of the tongue. And then you may not see those little humps on the tongue, the papillae, those little taste buds. So those might go away as well. So some of the causes of anemia are obviously malnutrition, or things that are iron not being absorbed properly, or there's blood loss happening, or some kind of hormonal issues, bone failure happen, or blood cells are getting destroyed, right? So some of the malnutrition that can happen, that you're not absorbing your iron or B vitamins are not getting absorbed, or you're just not consuming them through your diet, or you have dietary restrictions, or you're consuming too much alcohol, which limits the absorption of nutrients such as B complexes, different B complexes, and iron as well. Or maybe you just don't have enough stomach acid to help break down the iron properly. Sometimes you also have to think about, does this patient have an infection? Is there H. pylori in the stomach that's decreasing the acidity of the stomach and causing iron to not get absorbed? Or sometimes it's a more serious thing where you have parasites or celiac disease, or some people may have a leaky gut going on where they are just not, there's too much inflammation in the gut lining. Some people can be suffering from blood loss. Either they went through a surgery, or people who like to donate blood too often. That sometimes can be a problem. Unless you have iron overload, by all means, go donate blood until your iron levels are back to normal. Or there's an injury, or there's a bleed happening, inflammation of the stomach or the bowels, or there's some kind of GI bleeding that's going on. Females can have fibroids. So when fibroids are there, their iron demand goes up, and then iron utilization happens faster, which can cause heavy menstruations in some females. And of course, if a female is giving birth, there will be blood loss. Can you just see the cursor?
Yes, we can see the
Assume.
cursor.
Okay, perfect. Hormonal issues. Thyroid is an important hormone in our body, and it is related to anemia as well. What thyroid does, it stimulates metabolism, oxygen use, and indirectly helps EPO productions in the kidney, which is a kidney hormone as well. When the thyroid hormone goes down, the activity of the bone marrow also decreases, which causes the EPO signaling to go down, and EPO directly helps production of RBCs. So when that's a problem, there's like an like dominoes are falling down. Basically, that's what's happening. Sometimes you will see that if your metabolism isn't as great and you're more sedentary sometimes, the oxygen demand for your tissues will also decrease because you're not doing anything. Body's like, okay, this person is sedentary. Let's only do the bare minimum to keep the organs alive, but looks like they're not using their muscles. So we don't need to push the body to make as many RBCs, right? So typical symptoms that you may see when thyroid hormone dysregulation is happening is fatigue, weight gain, cold intolerance. And when that's starting to fall into anemia, the downfall is happening into anemia patterns as well. The patient will look a little bit more pale, and there will be weakness as well. Or there's a testosterone issue that's going on. Testosterone directly impacts the production of the EPO in the kidneys as well. That also acts on the bone marrow to help produce red blood cells. When the testosterone goes low, EPO production also goes low, then you make fewer red cells. Okay, so sometimes this can cause mild to moderate anemia. And when you also have a patient who has a low testosterone, you'll see fatigue, low lipido, muscle weakness that will be combined with anemia as well. And the EPO, erythropoietin. This is a glycoprotein hormone that's produced by the kidneys, and it helps with the RBC production. So same thing, that goes low, you will have anemia because you're not producing enough red blood cells, which causes the hemoglobin to decrease as well. Another cause of anemia is bone marrow failure. Sometimes you just stop making enough blood cells because there's an autoimmune attack, or there are toxins in your body, whether they are drugs or chemicals or certain medications that are causing it. Sometimes it could be viral infections such as parvovirus, Epstein-Barr virus, it could be HIV, cytomegalovirus. Viruses like these can cause you to have aplastic anemia as well. Or sometimes you don't even know why the bone is failing, so that's an unknown in the medical mystery, right? Or you can have myelodysplastic syndrome, where the bone marrow makes blood cells that are abnormal or dysplastic, and they don't mature properly due to a person's age. Maybe they're an elderly, or you just had a chemo or radiation therapy that has damaged that pathway, right? Or you're suffering from a bone or a colon cancer that can also lead to bone failure, bone marrow failure. Some people may have inherited hemolytic anemia. That's when the blood cells starts getting destroyed. There are a few different types. One is sickle cell disease. You'll see mostly that in African American populations typically tend to have a higher incidence of these, where you have abnormal hemoglobin, which causes the sickle or like crescent moon shapes of the red blood cells. And sometimes these can get stuck in the spleen and then they get destroyed. Or you have G6PD deficiency, which is an enzyme that helps protect red blood cells from oxidative damage, right? So you can have oxidative damage when you take certain drugs, if there are infections, and if somebody has this deficiency, and if they're eating too many fava beans have lysine and conlysine components in them, which impact the G6PD, and it causes them to not get utilized properly. So you want to make sure that people who have this particular deficiency, they're not eating fava beans, okay? Or sometimes what happens is your red blood cells are not getting proper shapes, and they become a round, fragile RBCs, which also then can get entrapped into your spleen and get destroyed. So either they are sickle, look like crescent moons, or they look like sphere round figures. That will also cause destruction of the red blood cells, leading to hemolytic anemia. So before we covered all of these are hereditary, so they can be passed down generations. Then you can acquire anemia as well, right? Body, for some reason, is attacking the RBCs. We don't know why. It could be viruses, infections, chemicals, toxins, whatever. For some reason, body's like, I'm going to attack these RBCs and we're going to destroy them, right? So that will be an acquired hemolytic anemia, acquired red blood cell destruction. Or you have infection like malaria that invades the RBCs directly and it destroys them. Or you can have sepsis or toxins that can damage membranes when you have some kind of infection. Certain drugs like penicillin, sulfurs, snake venom, or lead can also destroy red blood cells. Or some people have heart valves put on them, so sometimes they are not perfectly smooth heart valves that they get replacement with. And that can sometimes cause a lot of pressure on the RBCs, which causes them to become shredded under high pressure because it just isn't smooth enough like the actual heart. So that colliding with the surface of the mechanical heart can destroy the RBCs and causing anemia as well. So we call that a mechanical hemolysis, which shortens the RBC lifespan, leading to anemia. Whenever I am running, whenever I'm running blood panels I usually run them through Quest Labs. And most of the time, patients are always concerned able with this get covered. When you put in metabolic syndrome or other fatigue, most of your blood tests will get covered. Sometimes you are suspecting that patient has anemia. You don't know that what kind of anemia you have. So having metabolic syndrome or other fatigue, you can take a picture of this or a screenshot if you like. You can use these to order labs through Quest Labs, LabCorp, or whatever else lab you use. And once you know more, you can do a proper differential diagnosis. And if you don't know which anemia your patient have and you need something else, this is a great website, icd10data.com. This will also tell you if the codes are reimbursables that you're putting, because the last thing you want is putting an incorrect code and then sending the patient home with a massive bill. Don't do that, please. Sometimes it can cost patients anywhere from $1,000 to $2,000. So inputting proper codes will really help the patients and the insurance company know what you're doing, and the lab will get paid properly. Okay. So the labs to run, this is fasting. So about 10 to 12 hours of fasting. When we want to look or explore anemia, we run CBC, we run iron panel, we run total iron binding capacity, percent saturation, ferritin, intrinsic factor antibodies if you're suspecting an autoimmune process, and of course B12 folate and homocysteine, because those are necessary. Well, B12 and folate are necessary for red blood cell production. Homocysteine is a marker that I like to use, and this is a specific code you must use when you are suspecting high homocysteine in these people, usually when they don't have enough B12 and folate. Insurance will not cover the test if you don't put this in. Okay, so when you suspect that the patient is having this, input this code so the homocysteine test also gets covered. Otherwise, the patient will get a massive bill as well. Okay, homocysteine, we will talk further about this in the next slides. So when we are looking and we have gone through with our CBC panel, this is normally what you will see, plus you will also see white blood cells and the differentials for the neutrophils, lymphocytes, eosinophils, monocytes, and furthermore. So when we are doing an RBC is basically the number of blood cells you have. These values, most of them are, I use Quest Lab, so that's the values I'm inputting because that's the standard medical blood labs, right? Sometimes the ranges can be very large because these are averages over several data populations. But the problem with conventional medicine sometimes can be because the ranges are so large, people come in and they're like, oh, my blood tests are normal, but why do I still have symptoms? So when you see that the average human population, they're not energetic anymore. They're more like fatigue, disease, or at a dis-ease of some sort. And even though their labs are normal, they don't feel normal because the ranges are so large. So in functional medicine, if you are too close to either end of the ranges, that is starting to become a problem. Don't let this go into a pathological state and then be like, okay, now we help you. Start helping them when they're already reaching towards those end values, either it's a higher end or a lower end. Okay. Hemoglobin helps carry oxygen. It's also the one that helps give red color to the RBCs. Hematocrit is the percentage of the RBCs in the whole blood volume. Then we have MCV, which helps us determine the size. Then we have MCH, which helps us determine the mass and the color of the RBCs. Then we have MCHC, which helps determine the concentration of the hemoglobin, and it also helps give color to the RBCs. And then, of course, we have how big the width of the RBCs as well. And this value tells us what's the variations among the different widths. Okay. In iron, And of course, then we also run our iron panels. This marker is not good to see if someone has anemia. This is a good marker to see how much iron you have in the blood. And if this is a marker for iron overload, that's also a good indicator for this, but not for anemia. Okay. Oops. Let's go back. Oh no, how do I go back? Okay. And as I mentioned earlier, iron overload tends to be more for male versus females because, again, men are not losing blood or menstruating, right? So they tend to hold on to iron a lot more than females do. So we want to make sure that men are not eating out of cast iron, taking supplements with iron. Otherwise, it can cause free radical damage in their body. When somebody has hemolytic anemia, for example, where the RBCs are getting destroyed, the body loses iron as hemoglobin breaks down, but it also increases ferritin, which is the iron storage, and iron saturation, which indicates iron overload, not deficiency. So in those particular anemias, you will see that there's an increase in iron saturation, not necessarily deficiency in that. Okay. While the overall body iron may not be deficient, the process of hemolysis often results in iron being lost to the body through urine when red blood cells rupture in the bloodstream. Okay, so some practitioners start to get worried when the iron goes below like 70 or 75, and they're like, oh my God, your iron is low. Let's supplement you with iron. This is the range I tend to look at. If this is too much, let's think about, if it's more than 130, I think about iron overload. If it's less than 85, I start thinking about iron deficiency, but not supplementing them with iron yet. Okay, I will tell you that in a bit, why we don't supplement people with iron when we see that pattern. Okay. Total iron binding capacity, that's the ability of the RBCs to be bind to transference. Okay, that range is large. That's the medical range. This is the functional medicine range, 250 to 350, and then we have iron saturation to 25 to 32, functional medicine wise, and it tells us the capacity of iron to saturate the transference. Transference is a transporting molecule. Think of transference as that. Ferritin. That's the one that helps us tell us how your iron is getting stored in the body. If your transference is not below a 10, that's when most functional medicine practitioners don't give iron. So if it goes below 10, that's only when they will do it. If it's not below 10, we don't supplement them because there could be infection in a person's body. And if they're not digesting or breaking down their iron properly, what happens when you take a supplemental iron, it doesn't get broken down in the stomach, then your bacteria will get fed, or the pathogens in the GI tract will get fed, and it can also cause free radical damage, and that's not what we want when there's infection happening. So we want to make sure that you are breaking down iron properly, you're utilizing it properly before we supplement it. Now, if it's below 10, by all means, rule out infection, give iron supplementation. If that is enough, send them out to get iron infusions. Okay, but some practitioner will start supplementing when ferritin is 25 or below 25. Not a good idea for most cases. Okay. In some cases, ferritin can go high if there is inflammation happening. So if there is a relatively, assuming all blood markers are normal, ferritin is high, CRP is high, ESR is high, or white blood cells are high, that's an acute phase reaction. That means there is some kind of inflammation happening in the body that needs to be taken care of. That means either there's infection, some kind of toxins, or something is going on that the body does not like. Okay. Or another marker is if you have someone who has B12 deficient anemia, and you are giving them, or which is also called megaloblastic anemia, we'll go over that in a bit, and you're giving them B12, or oral B12, supplemental B12, and their levels aren't going up, they may actually have antibodies against the intrinsic factor in their GI tract, small intestine. When they have that, it limits the capability of B12 getting absorbed into your small intestine. So if that is positive, they may need to actually get infusions weekly, most likely for the rest of their life, with B12. Okay. And B12 is very important because it helps convert food into energy. It helps make white blood cells, and it's also necessary for nerve function. Okay. B12 by itself is not a good marker because most of the companies are testing just B12 or cyanocobalamin, which is the less usable form of B12. Methylcobalamin is a better marker to test B12 deficiency in the body. If methylcobalamin is too high, that means you're not utilizing B12 properly in the body. And another marker is folate, which is required for DNA synthesis and new cell formation. When these two go low, you will most likely will have an anemia. And the other marker I like to test is homocysteine. Medical people like to see that less than 11 or equal to 11. In functional medicine, we like to see this 7 or less. Because in research, what we have seen is when it starts to go above a 7, neuroinflammation can start, and we don't want that because homocysteine needs to be broken down with your B vitamin. So sometimes if this number is too high, sometimes I don't even test these. I just test homocysteine. If the homocysteine is too high, I immediately supplement people with B complex, or I have them get B12 shots to get that number down because this homocysteine is extremely inflammatory to your blood vessels. Think of it like a claw. It scratches that blood vessels and then the blood vessels start piling up more cholesterol and starts hardening them up. So we don't want an atherosclerosis happening when homocysteine is too high. We want it to be broken down into cysteine and methionine, which is more usable by the body. Okay. And when your blood vessel starts to get damaged, you're more at risk of having blood clots and increasing risk of heart attacks, strokes, or other heart diseases. Alrighty. Let's look at now for classification of anemia. When we think about anemia, we're thinking about red blood cells being low, hemoglobin being low, hematocrit being low. Stage 1 of most anemia is ferritin being low. So when you start to see ferritin less than 10, they may not have reached, for example, iron deficiency anemia, but they're progressing there. So we will talk about how we can increase that later on. Okay. So this is the classic classification of anemia, and then we can further see how they're divided. So if the cells are normal versus depressed versus elevated, or if the color is normal, less, or darker. Okay. So when we see small size or pale color, we call that microcytic hypochromic anemia, right? This can have your iron deficiency anemia in there. It can have anemia of blood loss. You will also can have anemia of chronic disease or inflammation because iron is getting utilized to fight all of that, or you have chronic inflammation because your GI tract is inflamed, or there's an autoimmune process happening like celiac is going on. Less common ones you may see are thalassemia or sideroblastic, where the immature RBC accumulate excess iron and then they start forming like a ring-like appearance. You can see that on a smear test. Or you can have different types of thalassemia, anemia as well. Or sometimes you see that the color and size are normal. We call that nomochromic anemias. This could be secondary to renal disorder. Remember the EPO, right, that we talked about? If that's not functioning properly, you can have secondary anemia because of that. Or kidneys are not functioning properly, you can have secondary anemia because of that. Okay. Again, chronic disease, chronic inflammation, acute blood loss can cause that. Hemolytic anemia can cause that. Another marker, you want to make sure that the bilirubin is not too high because that can go up when the hemoglobin is getting broken down. Another marker is LDH, which can increase when RBCs break down. Okay. Less common ones you will see are bone marrow failure or aplastic anemia, myelodysplastic anemia, and the other ones as well. Right. So all these are the ones you want to pay more attention to. They are more common ones. Some of them are genetics. Some of them are autoantibodies. So this chart can help you figure out what kind of anemia you're dealing with, and then based upon that, you can help your patients. And of course, ferritin should also be here because low ferritin will also cause anemia because that is your iron storage. Okay. Now we just talked about RBCs being down, but what happens when the RBCs are up? Some people have genetic disorder where they just keep producing more and more RBCs. We call that polycythemia, primary polycythemia, which is just a genetic disorder. You're going to have normal EPO, but RBCs will be up. Sometimes you're living at a higher altitude, or you have a lung condition going on. That can also cause increased demand of RBCs because the body thinks there isn't enough oxygen to transport. So the body starts increasing more RBC productions in efforts to supplement that low oxygen state. Okay. Sometimes you can also see, you can do like a pulse ox test in certain individuals. You will see that if the oxygen saturation is less than 95%, that's when we start to get concerned, because we never want less oxygen in the body, because especially when it comes to brain health, because when that happens, your brain is at risk. Your neurons are very sensitive to oxygen levels. So when oxygen is going low, yes, you're having physiological issues, but then you will also start having neurological issues later on in life. Okay. Patient can simply be dehydrated and causing RBCs to go up. Okay. Other one is bone marrow proliferation disorders, like myelodysplastic. You can have cancer, right? Or a kidney disorder that we talked about. So that can all produce RBC production in efforts to balance out whatever other dysfunctions that are happening in the body. Okay, how are we on time? Okay, the big thing, how do we manage anemia? Number one, you have to perform your history. It is crucial. You have to do your physical exam. Unfortunately, for functional medicine field, sometimes we do too many telehealth calls that we forget the essence of the physical exam. But acupuncture does not have that issue at all, because you guys are doing visual inspection, you're doing pulse checks, you're looking at the tongue, which is phenomenal, right? And then ordering appropriate labs, or if you're not ordering labs, at least know how to read them. You can order blood test, H. pylori infection, auto antibody testing. And when you implement your strategies, whether it's the herbs or supporting the spleen or kidney, however you guys support the state of anemia, try to retest to see, did our management worked? If it didn't work, what else are we missing, right? Digestive fire might be down in the body. That means the stomach acidity isn't enough. Maybe that's because of H. pylori, or there is some kind of other disorder happening, or the thyroid hormone is low, which doesn't help the proper secretion of the pancreatic enzymes in your stomach. Sometimes you can have a sluggish liver that can also decrease digestion capacity of your nutrients. So you really have to look at digestion first, and before we supplement people with iron, right? Iron is very inflammatory when it's not utilized by the body properly, okay? Start people with iron-rich foods such as eggs, liver, beef, leafy greens, legumes, nuts, lentils, and make sure that they are eating all of that. The problem in America is we are all accustomed to SAD diet, or animals that are fortified with all these minerals. So we want to really make sure that we are eating a wholesome diet and not just, pastas, breads, dairy, and that's the limit of our diet, or just bacon. You want to make sure everything is in balance at all times. Acupuncture is all about balance, I'm assuming. I think you guys are all about balance. And I also like to practice like that, like be in balance, don't do too much of anything, because too much of anything is bad, right? Making sure that person has methylated B complex and not synthetic B complex, especially folate. Folic acid is synthetic, it is man-made. For certain individuals, it can cause anxiety. So always look for methylated folate, or methylated L-folate. That's the one you want to give to your patients. Okay. Copper is also essential for red blood cells production. So is vitamin A, and so is vitamin C. So you want to make sure with the treatments that you're giving your patients, you're also incorporating the nutrients they need to make the blood cells and the food that they're eating. And make sure they are also on some kind of digestive enzyme, digestive bitters, or hydrochloric acid. A little caution with the hydrochloric acid or hydrochloric acid supplementations, or betaine hydrochloric acid, is if they have an ulcer, it will irritate the stomach lining, and it will make their symptom a lot worse. So whenever you find someone has an ulcers, you must help support healing of that ulcers. That can be done through utilizing L-glutamine, marshmallow, ginger, licorice root, zinc carnosine. Things like that will help repair the gut lining. Short chain fatty acids, things like that will help repair the ulcer as well, or help support in repairing the ulcer. And make sure you don't have H. pylori infection. So if you have H. pylori infection, most of the conventional medicine, what they do is they put you on PPI, proton pump inhibitors, and then they give you an antibacterial. Problem with PPI is H. pylori thrives in a basic acidic, a basic stomach environment. It dies in an extremely acidic environment. So sometimes if a patient is on PPIs for too long, you're not really helping the H. pylori infection. Yeah, you are helping the ulcers so that the stomach doesn't get irritated. But if you don't kill the infection in a timely manner, and the patient is like, I'm still having acid reflux, for example, I'm still having heartburn, you gotta give the patient nutrients. Vitamin A, zinc carnosine, L-glutamine, ginger, marshmallows, slippery elm. All of these things can support that ulcer lining. Cabbages are great as well. Caution with cabbages if somebody has SIBO, because it can make them a little bit more gassy. And of course, ruling out infections. Another ways to test H. pylori is urea breath test. You can do stool testing for H. pylori as well. If somebody has high white blood cells, typically I like to see if the range of white blood cells in a functional medicine world, I like to see between 5 to 8. If they are too low, I'm thinking chronic disease, chronic autoimmunity, or chronic inflammation, or protein deficiency. If they are more than an 8, I am thinking maybe this patient is going towards infection or recovering from an infection. So then I try to look at the percentages of neutrophils, basophils. Neutrophils are for your bacteria infections. Lymphocytes are for your viruses. And eosinophils are for your parasites or food allergies. And then you have basophils that are more like, they can go, or monocytes that go up initial phases of infections. So when you start to see them at a higher end, think the patient is either recovering from an infection or they're starting to have an infection. Okay. So dealing with the pathogen is very important. Making sure that the digestive fire is good, making sure the stomach lining is good, making sure that the patient's diet is proper, micronutrients are there, they're eating iron-rich foods, their digestive fire is top of the class. Okay, so figure out all of these before you give them iron. Otherwise, it will cause free radical damage due to undigested iron. And if you don't use iron properly or digest it properly in your stomach, bacteria will feed onto it, and there's a chance of worsening an infection. Okay. And whenever you're like, hey, I don't know what's happening, but I can understand this, but I need some more help, get an MD involved, get a hematologist involved if you're dealing with some kind of genetic issues, because for certain peoples you may need blood transfusions, iron fusions. Unless you're if you're an ND, you can probably do iron infusions, but send them to an MD and a hematologist. My rule of thumb is I always tell my patients I'm not an MD. Most of the things I do are more lifestyle managements. I do give them a disclaimer. These are supporting things. I'm not trying to cure you of anything as a functional medicine practitioner and as a chiropractor, because I'm not licensed to do that. I need to have your MD on standby at all times. If something goes off, we need their help. Okay, because we are a team with all the healthcare professionals. We are not just, some people have like, oh, don't do this, or oh my God, all medicine is evil. That's honestly an uneducated mentality or inexperienced mentality. Medicine is needed when it's needed. Overuse of medication is bad. Not taking medication is also bad. So always we want to strive for that balance. Okay. Oh my God, we are done with anemia. And we have a few question answers, comments. Should I do stop share? Let's try that.
Okay, so far we don't have any questions in the Q&A box. So for all of you out there, do you have any questions about the first section on anemia that Dr. Bhatti can answer? No, no one. I have the Q&A box open. Everybody understood everything? There are no questions. Grace says, this is great. Thank you. Thank you, Grace, for making your comment. We appreciate the feedback. Dr. Bhatti also feeds the backpack. Oh, okay. Tronica wants to know how to address free radical damage from too much iron.
If somebody has too much iron in their body, they gotta go donate blood, especially men. If your iron starts to go above 130, start thinking about iron overload. We don't want that, so donate blood as much as you can. And once your numbers are back to normal, then you're fine. And if you're taking iron supplements, don't. That's how you stop it from happening. So remember, work on digestion first, then give them supplements.
Just would
Would
like
you
to
please review
know.
what you said
Go ahead.
about high and low values of B12 and folate? Already. So when B12 and folate are not enough in the body, you will, let me actually share screen. Where is it? Share screen. Oh, slideshow. Okay. When B12 and folate when B12 and folate are too low in the body, one, you're not getting it through your diet. So you have to supplement that, right? B vitamins normally don't cause any issues because they are water soluble and your kidneys excrete excess out. When they are too low, you will not synthesize your blood cells properly. So you want to make sure you have adequate amount at all times. B12 by itself is not a good marker to see if you have proper B12 in the serum. You want to test for methylcobalamin, which is the active form of B12. Okay, that you want to make sure is getting utilized properly. And the other marker I like to test for B12 utilization or B complex utilization is homocysteine. If homocysteine is too high, sometimes I've seen this as high as 14 or 19 or 20 in some people, you need to get B vitamins so you can break this amino acid down into methionine and cysteine. Okay, so what else? If B12 is very high sometimes, you can also have a genetic disorder where you're not converting your B12 in the active forms. You can have MTHFR, for example. You're not converting your B12 properly, then you will see that your methylmalonic acid is on the lower end. Yeah, because you're not utilizing, or because it's not getting converted properly. So you want to make sure that you're testing methylmalonic acid and not necessarily B12 by itself. Does that help? I hope it does. Do you have any cause for concern when intrinsic factor is, say, so in the world of autoimmunity, when you have a positive value, you're concerned. Because sometimes patients can have different stages of autoimmunity. Sometimes they only have intrinsic factor antibodies are high, but they are not symptomatic. So when it's high, that's stage 1 of autoimmunity. Now, stage 2 would be now they have high or positive intrinsic factor antibodies, plus they now have symptoms. For example, nerves are getting damaged, blood cells are not getting built. And the third one would be stage 3 of autoimmunity is when you have positive antibodies, symptoms are there, and now when you do like say MRI or something, you see some kind of nerve damage. That becomes, or when you take a biopsy of the small intestine, you may see damage there because the parietal cells are not functioning properly to absorb B12 in the small intestine. Preferred source of iron if oral supplementation is needed. I don't think I can give supplement company recommendations. for this seminar because it has CEUs, but try to find one which has cofactors in it, like B complex, vitamin C. That will really help with the absorption of iron. Find the ones which have these cofactors plus hydrochloric acid in it. So that will also help. Will there be any hands for this presentations? We don't know. Are we getting access to slideshows? I don't know yet. I had a hematologist give iron infusions at 12. Could you talk a little bit? The cutoff at 10. Sometimes it's case by case basis. For example, one time I referred Dr. Julie a patient where the iron was extremely low and ferritin wasn't below 10, but like close to 12 and 11. This was a young child, maybe 16, 17, 18 years old. We were like, we need iron infusions right away because she has so much fatigue in her. We did rule out all other things. The second we gave her iron, her fatigue was non-existent. So it's just case by case basis. These are just guidelines. You really have to weigh your options at every single stage. It's not like these are hardcore guidelines but they're guidelines to follow. But your clinical experience will tell you where and when to do what you want to do. Would you avoid supplementing with iron in patients with low ferritin if they also have gut dysbiosis? For that particular patient, I would fix the gut lining, go after the microorganisms by giving them antimicrobial herbs, see if that helps that, increasing iron-rich foods. If they're not making a dent in the concentration of their ferritin or iron, we may think about it afterwards, but if that, sometimes alone, I've seen that marker just go up because the patient is eating right, you're taking care of the infection, they are able to digest iron properly, and that alone is enough to get the iron up. Apart from RBCs. You can do, so to analyze gut microbiome, you can do stool testing. If you're concerned about leaky gut, you can do, can I say lab names or no?
Sure, but you have to list a bunch of labs. You can't favor one or the other.
Got it. I'm going to just say, look for the lab that is offering zoline including antibodies or actin-myosin antibodies, and that will help you determine what kind of leaky gut they may be having. Actin-myosin is when the cell itself breaks apart. Sorry, I probably cut the mic off. Actin-myosin, so pretend these are cells. Okay, these your villi are just one cell line thick in your small intestine. So when you have leaky gut, either the cell junctions are breaking in between the cells, which is causing leaky gut, and so then the gut barrier and the blood barrier has been breached, so the bacteria can go into the blood. Right? Those are called zoline occludin. Okay. Now, if the cell itself is breaking in half, pretend this is one huge finger, which is one cell. If that's splitting in half, that is actin-myosin antibodies you want to look for. And if that's present, that's a harder one to heal. Or it's something will take longer if you have LPS in your blood, which is lipopolysaccharides, which is for membrane of the gram-negative bacteria. If you're making antibodies to that, that means the blood has been infiltrated with your gut bacteria, which is never a good thing. That's a very inflammatory process for the body, and it can cause endotoxemia. Ideal iron, 85 to 130. Sometimes when somebody has 70 or 75, I'm not too worried. I don't supplement iron until the ferritin is low, below 10, and symptomology as well. Supplement iron as the last resort. Can you please explain how do you classify for serum ferritin lab test? I have seen it very high, however, after PCP. Unfortunately, with the medical training we have right now, so the question was, can you please wait? Not everyone can see the questions, right? Can everyone see the questions?
Everyone
So
should
can
be
you
able
please
to see the
explain how do you
questions.
do okay. Can you please explain how do you do calculation for serum ferritin lab results? I have seen it very high. However, after CPC, primary care provider does not does certain calculations, they are not concerned. Patient's main symptom was joint pain. Based upon the way the medical treatment, conventional medicine has been taught, they have their own guidelines. Whereas functional medicine is after everything. It's like, okay, why are you having this? Whereas for conventional, if there's not a pill to fix something, they usually are not concerned, unfortunately. So that's where the functional medicine mindset or investigative mindset sets in, like, why is this ferritin high? Infection. Honestly, some of my times I have seen people with very high eosinophils, which are for parasitic infections, and the MD and the patient has stomach pain when they eat, and they're like, oh, nothing is abnormal. And then I'm like, patient, you have parasitic infection. We give them herbs, for example, and it helps support that parasitic infection. And then they're like, oh, I don't have the symptoms anymore. Like, yes, because you had parasitic infection. So it's just based upon how they are trained. Iron bisglycinate, oh, that's fine. Which iron supplement do you like or to use or have a good absorption or less? So again, the ones with cofactors. So find the ones with cofactors, and you will have better beneficials through that. All right, it's 8:11. It's time for your 10-minute break.
Before you
Thank
go
you
on
for
your
your
10-minute
questions. They
break,
were very enjoyable.
if you stay to the very end and we conclude, Dr. Bhatia is done, he can list out the lab companies he uses and the exact
Oh, yes.
company for supplements for iron or whatever else he's talking about, but he just can't do it during the CE hour. So if you stay to the very end, he will list all that out for you if you really want to know the certain labs, the actual lab companies he uses, and the supplement companies that he uses and prescribes to his patients. Okay, but enjoy your 10-minute break, and we'll see you back shortly.
All right, see you guys at 8:22.
Okay, everyone, we're gonna slowly trickle back in. Hopefully your Zoom is still on, so even if you're in another room, you can still hear us. Hope everyone had a good 10-minute bio break. Dr. Bhatti is back for dysglycemia. You ready to go, Dr. Bhatti?
Yes, I am. Can you guys hear me?
Yes, we can hear you. All right,
Perfect.
let's get started.
Before we jump onto dysglycemia, I just want to point out for the whoopsies, that's not what I wanted. For our B12 conversation, so when your B12 can be high in the blood, but your methylmalonic acid, which is the active form of B12, is low, which is a better marker of testing B12 anemia, that tells you that even though you have enough B12, it's not getting converted to its active form. So that's why methylmalonic acid is a better marker for B12 deficiency, because if it's low, that means there's an issue. And if you are not, and then that means you have to supplement with methylated form of B12 because your body may not be able to convert it to the active form, perhaps because you have a genetic defect that doesn't allow that pathway to get to convert to the active form of B12. Okay, so methylmalonic acid low is a better marker.
And Dr. Bhatti, how do you test for methylmalonic acid? Is it a urine test or is it a blood test?
Blood test. Blood test will always be better for most cases. Right. 10-minute break again. All right, dysglycemia. I feel like most of the world will have less problems if everybody can have their blood sugar balanced. Most of the problems in this world will go away. But that's not the case. So what is dysglycemia? It's the state when the body has too high or too low blood sugar. Okay, so and then that is causing you some kind of symptoms. And what may be those symptoms? So I've had hypoglycemia symptoms, and I've had hyperglycemia symptoms in the past 15 years, I would say. I've experienced both. So when you have hypoglycemia, that means low blood sugar, you may feel dizzy, you may feel lightheaded. Some people who have severe ones can be confused or having trouble concentrating. Some people get shakiness, which is very evident. Some people get anxiety or irritability. For kids, that is a big sign. When the child becomes anxious or becomes irritable, think about maybe they are having a low blood sugar drop. Okay, shakiness, lightheadedness, sweating, chills are a little bit more extreme. Sometimes they're like rapid, fast heart rate. Some people get extremely hungry or hangry, right? More severe one is the blood sugar is crashing. That could be due to, oh, hold up. Oh, okay, it's there. Blood sugar is crashing. That means you are having double vision. You can't talk properly. Your speech is starting to slur. You're feeling a little bit clumsy, or you're bumping into things. Or some people have loss of consciousness when it drops really low, or some people starts having seizures. For others, or for some who are experiencing both, can have high blood sugar symptoms where they are constantly thirsty, they're constantly urinating, they can have headaches, they can also have blurred vision. And when this keeps going for long term, you will start seeing that these people have low metabolism that will cause them to have increased weight gain, fatigue, slow wound healing, right? And of course, when you have full-blown diabetes, you can have vision loss, you can have kidney failure, you can have neuropathy, in your feet where you stop feeling your feet, and then once you stop feeling temperature or sensation in your feet and you get infected or something or burn marks, you won't know. They will have to amputate for certain cases, for very severe cases. And for females, when their blood sugar is extremely high or out of control, they're more likely to have yeast vaginal infections or vaginal infections in general. For certain females, I have seen the second they eat like very sugary cakes or pastry, the next day they're like wake up with UTI. They're like, what happened? It was as simple as eating that piece of cake for certain individuals that don't have a proper microbiome balance. So what can cause dysglycemia? So when there's low blood sugar state, often that's considered medically less than 70. Okay. When there's a hyperglycemic state, that is considered more than 125 fasted or more than 180 fasted, after meals. Okay. So those are good benchmarks for you guys to know, because some people may be using CGM. And so these are good values to know for CGM marker as well. Of course, your blood sugar will shot up sometimes after you eat, but then you want to make sure it also comes down within an hour or two of eating. But if it shoots up to 180 and above, that's when we start to get concerned. Okay. Or if it's more than 140 after 2 hours, that's also concerning. Okay. That's also a test you can do through Quest Labs, for example, or LabCorp, where they make you drink a liquid and then they test your glucose after an hour, after 2 hours, after 3 hours, however many hours you want them to test the patient for. Okay. For a hypoglycemic state, you can have too much insulin, or the patient is on diabetic medications, or they're using insulin injections. Now, there is, for example, berberine, right? Or berberine is like a natural metformin, so to say. So if someone is taking metformin and they decide to take like herbal berberine, that will crash their blood glucose. You want to be really careful. There's an interaction there. So don't give people like, hey, you can have some berberine while you're on metformin. Bad idea. Will crash their blood sugar dramatically. Okay. Skipping meals or delaying meals, that can be an issue for certain peoples who don't have the metabolic flexibility from going from burning glucose to burning ketones. Okay. So if you don't have that metabolic capacity, it's not a good idea for you to be skipping meals. Okay. Or somebody who did too much intense exercise and they just burned off all their glucose stores, because muscle burns glucose faster and they have depleted all their reserves. That can also cause an hypoglycemic state. Okay. Alcohol, it blocks the liver's ability to release stored glucose, especially risky if not eating. So if you're gonna drink alcohol, which I don't advise everyone to be consuming so frequently, eat something with it. Okay. And if you do decide to drink alcohol, do some liver cleanse afterwards as well. Unless the other problems you can have with hypoglycemia is critical, like some kind of infections or organ failures, whether it's your liver, your kidneys, or you're having sepsis, which is blood illness. You're having some kind of bacteria endotoxemia happening inside the blood, which can impair glucose regulation. And then you can also have hormonal deficiency or hormonal dysregulations. You can have cortisol for some certain people. If it goes too high, it can make push them towards a high insulin state as well, or a high blood sugar state, I should say. So having low cortisol, low growth hormone, glucagon deficiency, all of these can also cause people to have hypoglycemia. Reactive hypoglycemia. It's if you have like it's for people who sometimes are skinny or they eat very infrequently, they're fasting, and they go up and they start eating chips. Or people who just had a meal and they're craving sugar after like an hour or two, or dessert after eating, they may be going through hypoglycemic state or reactive hypoglycemic state, where you may not have a true hypoglycemia, like less than 65, but you are showing patterns of that. Okay. Some people have a pattern where they are waking up in the middle of the night around 3, 4, or 5 p.m. very hungry. That means their glucose just crashed and they're looking for food. And their cortisol goes up because it's fight or flight. Your body's like, not enough glucose, fire up the kidney, fire up the liver, wake this person up, make this person eat, release glucagon from the liver as well. Use the reserves because they're not metabolically flexible to go from glucose to ketones. Okay. Hyperglycemia, of course, you have diabetes, either it's type 1 autoimmune, type 1.2 autoimmune now, type 2 insulin resistance. I was just reading recently, now there's also a type 5 diabetes. The other diabetes is called the Alzheimer's. I believe that might be type 3. Don't quote me on that. So there are different ways of now describing high blood sugar states, whether it's in your brain, whether it's in your pancreas, whether it's in your blood. They're just different names of diabetes now. Or you have infection or stress, blood sugar rises because your body is having to utilize more energy to deal with stress or deal with infections. You're taking some certain medications that can increase your glucose. You're eating too many carbs. You're eating SAD diet or standard American diet, and you're not exercising enough to help your insulin become sensitive to push whatever the glucose that you're breaking down from your food into the cells. Or you just like to sit a lot, or you're very sedentary, or that is also low because your muscle activity goes down. The body's like, we don't really need to use this glucose. Let's just keep that in the blood. And then your insulin sensitivity also decreases. So sedentary lifestyle increases mortality rate a lot for various different reasons. Okay, so don't encourage your patients not to be sedentary. Okay. Endocrine, some kind of hormonal disorder is happening. Too much cortisol is being produced because the patient has Cushing's syndrome, or they have excess growth hormone, or they have excess adrenaline, which is causing blood sugar to rise up. Okay, fight or flight, you need more glucose so that your cells can have power. So in case you need to run, it's ready to go. Okay. For certain people, if they are skipping the insulin shots or infusions or therapies, or they're not using their medications, that will also that's a secondary to increasing blood sugar because they already have high, but now they're also not taking the medications that are now needed because the body has essentially given up. Okay. ICD-10 codes, 2 of my favorite ones. Metabolic syndromes, when you suspect patients has a history or family history of heart attack, stroke, type 2 diabetes, or you also find them they have high blood pressure, they have a history of high blood sugar, and if you see they are having cortisol levels increase, and of course if they're obese, most likely they're having a metabolic syndrome, so that is a code you can use. Most of these patients will also be fatigued. Those are good codes to use. And of course, once you know what it actually is, you can further differentially diagnose what they're actually dealing with, what kind of glucose state they are in. Okay. Labs to run when you are suspecting some kind of dysglycemia: glucose, hemoglobin A1C, insulin, standard lipid panel, LDH, uric acid, C-peptide, and of course, then you also have your autoimmunity markers related to glucose or insulin. So when we are running labs, so the purple is functional medicine or functional medicine ranges, plus they are clinical polls. So look at the purple as that. And of course, there is no functional medicine committee that has been formed that tells you this is the range. We still respect the medical range. This is just what we see in practice and when people start to go worse. Okay, so these functional medicine ranges are not standardized. Okay, so don't confuse that. This is not approved by FDAs or anything or CDC. These are just guideline of what we think is the big word, is an optimal range. Okay, but this is what the CDC tells us. So that and FDA tells us that that's what you go with, and medical colleges. Okay. If below 70 or 65, medical hypoglycemia. If it's more than 100, possible insulin resistant or glucose intolerance. If it's more than 135 on more than one occasion, think about diabetes. Okay, this is like fasted states. Okay. If the patient has less than 85 glucose and their LDH, which is an enzyme, is less than 140, in functional medicine, this is a good indication for us just to tell them like, hey, you may be going through a reactive hypoglycemic state. You will notice that these people, they eat, and then after 2 hours, they are like craving coffee because they need that boost of energy because blood sugar went up from a high carb meal. Insulin came in and too much insulin was produced. It put the glucose back into the cell a little bit too fast, and then they crashed. And now they're like, oh, I need another dessert. I need coffee. I need my tea to pick me up because they don't have a proper regulation. It's of their blood glucose. It's crashing too fast. So that is a symptom of reactive hypoglycemia. Okay, hemoglobin A1C standardized, right? If it's less than that, this is very rare. I see reactive hypoglycemia or increased insulin secretion. I haven't seen hemoglobin A1. I've seen 4.8, but I've never seen 4.7 or less than that for now. Maybe I'll see it in the future. 4.8, 5.6, normal. I'm more like, hey, if you're going towards 5.5, hey, let's think about getting your value close to 5.5, which is like in the middle rather than being on either end of the spectrum, right? When you hit 5.7 and up, or 5.7 to 6.4, pre-diabetes. More than 6.4, it's diabetes type 2, right? Other thing to consider is that hemoglobin A1C is not just a marker for diabetes. It's also a marker of inflammation. When this is so high, you are inflamed, very inflamed. You need to get the inflammation out. You're just causing destructions of various nerves, kidneys, your eye cells, and various other destructions are happening in the body. You don't want that. So make sure you are always having your blood sugar stable for your patients and for yourself as well. Insulin, standard ranges are 18.4 or less. Functional medicine wise, we like to see that less than an 8. As it starts to creep up, we are more concerned like, hey, is this person becoming more and more insulin resistant? Okay. Of course, not approved by FDA or CDC. This is the medical range, which is accepted. Okay. So when you're between 8 to 18.4, that's a good education for you to tell your patients like, hey, let's start thinking about how we want to keep your insulin a little bit more active and sensitive to your glucose surges, so that you in coming years don't become diabetic. Okay. LDH is lactose dehydrogenase enzyme. It helps regulate energy metabolism by converting pyruvate to lactase when you're having low oxygen states in the body. This is your Krebs cycle. this process is called anaerobic glycolysis. It recycles glucose for continuous energy production. Okay, so when you are not having enough of this, your body is struggling. So let's not let it struggle. So when you see these markers, think about reactive hypoglycemia. This has to be true. This and this. If this is low, this is more than 140, they're most likely not having reactive hypoglycemia, but they can still have, blood sugar crashes, but not severe reactive hypoglycemia state. Okay. Uric acid is another unique marker that research is saying that for older adults, especially 75 and up, they are more likely to susceptible to metabolic syndromes and type 2 diabetes. So in males, this is actually this one I've seen in research where they're saying when this number is more than 6, even though the medical ranges for men are these, and female is from 2.5 to 7. When we start to see uric acid more than 5.5 in females or more than 6 in males, start thinking about insulin resistance. These may be normal, but start thinking about gout, insulin resistance. Some of these may be up or down, but even though they may not be here, right? They may not be pre-diabetic state, but they may be in the normal state. But you're seeing a female with a 6.5 uric acid and higher glucose of 135, but their hemoglobin A1C is normal, but their insulin is, I don't know, an 18. Then you're okay, you are developing insulin resistant patterns. We need to fix this. And of course, running a standard lipid panel, when your good cholesterol goes down, your bad cholesterol is going up, your triglycerides are going up, and you're having high cholesterol, that is metabolic syndrome. It can also lead to hyperinsulinemia. So make sure those are in good ranges as well. Okay, you want to have high triglycerides, high cholesterol. Medical ranges tend to be 150 to 199 usually. If your cholesterol is less than 150, especially for females who are females that are very athletic and they don't have enough fats, they will not produce their hormones properly. You want to make sure your cholesterol is over 150 fasted total cholesterol and less than 199 medically speaking. But I don't freak out. This is my opinion. If the patient's triglycerides are normal, but cholesterol is like less than 250, but their LDH is high, their bad cholesterol is low, I'm just like, oh, there may be more eating more keto diet or eating more fats, but they're also working out. So, just think about that as well. C-peptide, it's also released by pancreas. It helps to monitor how much insulin is being produced. If it's low, that could indicate low insulin production. Which can suggest type 1 diabetes, which is autoimmune diabetes, or severe insulin deficiency. Okay, for some reason, insulin just isn't being produced. There's inflammation of the pancreas, there's an attack on pancreas. So that's also a good marker for certain people. I don't always run this one. And if it's high, there's some insulin resistance happening. Okay. And now we jump into our autoimmune markers. Like GAD65 autoimmunity. So when GAD65 autoimmunity happens, so what happens is GAD65 helps produce GABA. GABA helps regulate insulin production. So when you start producing antibodies against your enzymes, they actually attack in the pancreatic beta cells. They starts getting destroyed. Pancreatic beta cells help production of insulin. So that starts to go down, which can push people towards type 1 or latent autoimmune diabetes in adults. So maybe they were not born with diabetes, type 1 diabetes, or this, which is more juvenile. But for example, they started to have need of insulin because their beta cells got destroyed because they started making GAD65 antibodies. And now they have autoimmune diabetes, which is called type 1.5. Okay. Or you have pancreatic islet cell antibodies because you start making antibodies to varieties of islet cells components, and there's an ongoing autoimmune attack towards them that can also push you towards type 1 diabetes or type 1.5 diabetes later on in life. Okay. I've seen some people who were completely fine and then maybe in like their mid 20s, all of a sudden they are type 1.5 diabetes. So that can happen too. Or you have IAA2 antibodies, which is produced against tyrosine phosphate in your beta cells and associated with rapid beta cell destruction, which helps produce insulin again. So when you have that antibodies, all of these can be done through Quest or LabCorp or whatever other labs you guys are affiliated with. Those are the ones I use. So type 1 diabetes or type 1.5 diabetes. Okay. Management strategies. This is extremely general. This is by no means comprehensive when it comes to management because everyone is just so unique in their presentations. But because of time, we don't have too much. I had made it very basic. So of course, take your complete history, do your physical exams, perform the laboratory tests, and then track the patient's progress in 3 to 6 months. When we're dealing with dysglycemia, always start with diet and exercise. Okay, unless the patient is coming to you and they have hemoglobin A1C of 7, they need to be put on medication. That is way too much inflammation. They need to get that under control. Send them to their MD, endocrinologist, or ND to get that put on metformin, for example, and get that that blood sugar under control. Okay, always guide your patients towards eating more healthy fats, healthy proteins, and complex carbohydrates, as opposed to eating more starches or simple carbohydrates. Okay, simple carbohydrates, because they don't have a complex fibrous structure, when they raise glucose a lot faster than something that has a fiber mesh, which slows down the glucose surges in the bloodstream. Okay, so some strategies are eating your salads first before your main course. Some people like to use apple cider vinegar, for example, because it acidifies the stomach and increases digestive capacity. Some people like to use apple cider vinegar. Other people who are normal, not on metformin, they may be using berberine because they are not diabetic yet, but they may be heading towards that. And exercise isn't doing enough sometimes. Exercise, honestly, is by far the best medicine when it comes to lifestyle diseases, whether it's cardiovascular disease or blood sugar diseases. Make people exercise, most of their problems will go away. Fix their diet, most of their problems will go away or become less complicated. Okay, so exercises, for example, 30 minutes, 3 to 4 times a week, moderate to high intensity. I believe there is an equation for a high intensity workout, which is you do 220 minus your age, and you times that by 70. And that tells you you're 70% of your heart rate. And at that, if you're reaching that heart rate during your exercise, that is considered high intensity. Okay. Now, you don't necessarily have to be at that heart rate for 30 minutes straight. It can be for 5 to 10 minutes. For example, you're doing cardio, jogging, or something. Your heart rate is at 70%. Okay. So that's how you calculate. That is 220 minus your age. Whatever number you get, you times that by 70%. that gives you your max heart rate or for high intensity exercise. Okay. Some people I say like, hey, calculate 70%, calculate 65% of the number and try to be in that range. Okay. And try to keep that heart rate going for at least 5 to 10 minutes, take a break, go again. Okay. And of course, when someone is having hypoglycemia or reactive hypoglycemia, they will benefit more from eating more frequent meals or smaller meals, which are rich in fat and protein. Okay, not just simple carbohydrates. Starbucks is not your friend. Don't drink that. It's very sugary drinks. Okay, make your own tea or drink your coffee, for example. There is, although I was reading somewhere, I cannot back this by research yet because I don't have the research in front of me. But there is a researcher named Stacy Sim who was talking about when female drinks coffee before they work out, they are at more risk of using their glucose a lot faster than men. So for your female patients, don't advise them to drink coffee because they may dip into that hypoglycemic state faster than men. Most of the studies on keto diet, intermittent fasting are done on men. They are not standardized to women. Women sometimes don't do well on these keto diets or intermittent fasting just because of their hormonal needs, their hormonal fluctuation, and of course, because of the menstrual cycles. So you need to have a more balanced diet for a female. Okay. Hyperglycemia state, of course, intermittent fasting of 15 to 18 hours, 18 ideally, right? But don't start people right on intermittent fasting, especially when they have hypoglycemic state. They cannot switch their glucose metabolism rapidly to ketone metabolism. You will inflame them, especially if they have some kind of neuroinflammation or autoimmune disease. When they get down into those roller coasters, this is probably a better roller coaster, or dips in that blood sugar, they will become inflamed because this is a very inflammatory state. So you want to make sure that your patients always have a steady increase in blood sugar, steady decrease in blood sugar, but not dropping below 85 or 80 or 70, okay, depending on how they are utilizing the blood sugar. Okay, so exercise is important. Balanced diet is important for such individuals who have very high blood sugar because exercise will make your insulin more sensitive and basically help your insulin to push glucose into the cell. Okay, because the metabolic need has increased. And of course, don't shy away from medicine. People who have very high hemoglobin A1C, you do need medication. Miraculously, you do everything perfectly. Your numbers are looking great. Talk to your MD. See if you can get a lower dose of your diabetes medication, and eventually maybe you can get off. Who knows? But that's thing you have to discuss with your MDs. For certain individuals, consider CGMs. They're like, hey, I'm doing everything right, but why am I still having hypoglycemia? Or why am I still having high blood glucose on my lab test? It's probably because you may be thinking blueberries are healthy, but for their metabolic needs, when they eat blueberries, their blood sugar just skyrockets. Just because the way they're processing sugar, because everyone is individualized in their own biochemistry. I had a very type A patient. She's in LA. We see each other online. She's also a good friend now. She was very data driven. She's also a healthcare practitioner, and she decides to get CGM. She's like, Dr. Bhatti, when I eat a handful of blueberries, my blood sugar goes skyrocket and it stays high. And she was like, when I eat 5, it stays stable. But if I eat more than 5, I start to see fluctuations. So for her unique biochemistry, she was like, I can have this. If I do more, it gives me high blood sugar. So you may encounter some patients like that who are very data driven. So for them, CGM, continuous glucose monitor, they are free ones, not free ones, sorry. They're inexpensive one that don't require prescription anymore from the MDs. You can use that. People can buy that online. Usually they are for like 2-week trials. Sorry, 1 CGM for 2 weeks, and sometimes they're sold instead of 2, so 1 month learning opportunity for the patient. And of course, if you have auto antibodies positive, some people will need insulin therapy, or they will need autoimmune lifestyle management, which is very broad. Cannot cover that in 2 hours. It's very complicated because we have to deal with the immune system, we have to deal with blood sugar, sleep patterns, inflammation, infections, diet, food triggers, barrier systems, cross-reactivities of food, cross-reactivities of pathogens. And some people will need some kind of rheumatology intervention as well. So there's a lot there, but that's a gist of autoimmune management. It's very complicated. And of course, when in doubt, refer out and have nutritionists on your team. Sometimes you feel like we can do everything, but it's good to take some things out and give it to somebody else, so because they may have more knowledge on that. So I can help with most diet, but if somebody needs more specific diets, I just refer them out to a nutritionist who I know is like, I know a SIBO nutritionist, for example, is very good with SIBO. I know a paleo nutritionist who's very good with paleo. I know an autoimmune diet nutritionist who's very much focused on autoimmunity. Then I know a nutritionist who is a vegan or vegetarian nutritionist. So make friends in the community. And like, hey, I'm sending you a patient, they need help. And it's a great way for you to cross-refer to each other as well. Okay, special considerations and clinical pearls for dysglycemia. So a person with an average blood sugar often has high, longer survivability of their red blood cells. When someone's red blood cells survive for longer, usually a lifespan of a red blood cell is 120 days, right? Then they have more time to accumulate that sugar onto their red blood cells. For these individuals, they may result in higher levels of hemoglobin A1C, but their other markers may look completely normal. So that is a valuable thing that I've learned in my practice. Other thing is someone who may have diabetes or high blood sugar, their red blood cells are less likely to survive, or sometimes they may have anemia, Their red blood cells are less likely to survive or live for less longer time. They don't get enough time to accumulate that blood sugar onto their cells. Okay, so they may falsely have low hemoglobin A1C. So right now I do have a patient whose RBCs are very mixed pattern of anemia. I'm not quite able to figure that one out. But she's in a very inflamed state, and her hemoglobin A1C is 6.2 for the last year, but she's in a very high stressed state. I think she may be having this, like her blood sugar is a little bit on the higher end, but she's still pre-diabetic, but her blood cells are not looking that great. So I think she may be reporting low on hemoglobin A1C when actually she may be diabetic. So I'm still exploring that for her. So this is good for everyone to know. Okay, so if there's diabetes or high glucose, red blood cells survive less. less likely to accumulate more sugar onto themselves. So hemoglobin A1C can be falsely low for these people. And of course, hemoglobin A1C is also affected by anemia. That's why we did anemia and blood sugar together. When someone has anemia, of course, red blood cell life will also decrease, falsely low hemoglobin A1C. And once, say, you fix their anemia, and all of a sudden, they're like, oh my God, how am I diabetic when I wasn't before? It's because now the red blood cells are surviving their normal or longer time. And then now they are able to accumulate the sugar that was running around in their bloodstream that they weren't able to accumulate before. Okay, so these are very special consideration that you should keep on top of your mind when you're looking at hemoglobin A1C, red blood cells, and blood sugar markers. Oh, and we finished with blood sugars. Is there anything else I want to talk about? And this is an image. So pretend this is a graph. Okay. Pretend this is the y-axis with blood sugar. Okay. And this is time. Okay. When you eat something, blood sugar should rise, but it shouldn't drop. It should have a steady decline. Then say you eat again, blood sugar goes up and goes down. Every time there is a dip, 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 at that dip, for example, pretend this is a dip, 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 inflammation is happening, anxiety is taking place, hangry, person is becoming hangry, and they are becoming more agitated, they are becoming lightheaded, and then they're craving their quick life-saving decisions. Oh my God, I see chips, let me eat that. I see cookies, let me eat that. Let me get that Starbucks, let me get that coffee or whatever. Okay. You want to be careful when they hit there. When they hit there, it is kind of late already because they didn't have a steady decrease. Now they're inflamed, and that inflammation is causing more damage or more damage in the body. So we want to avoid those dips. We want to make sure it goes up, comes down steadily. So healthy fats, healthy proteins, healthy complex fibers, exercise, take your medications if you're on medications, intermittent fasting if that's inappropriate for that patient. But if they're having too many dips, smaller meals throughout the day, more fat, more protein, more complex fibers. Okay. Alrighty. We're gonna jump right into a quick overview of thyroid. I did not go into too much detail of thyroid just because of the sake of time, but because thyroid is also an important thing, let's go over it. Thyroid hormone is very essential for body metabolism, energy use, growth, temperature regulation, heart functions, brain, nervous system. Its thyroid hormone is utilized by almost every single cell in your body. Okay. And it helps regulate the cell rate work, heart rate, breathing, digestion, bone health, mental activity. So thyroid hormone is very important. Okay. These are quick signs and symptoms of hypo and hypothyroid state. These individuals you will see with hypothyroid state, they are on the skinny side. They sweat more easily. They're sensitive to heat because their body temperature tends to be high. They have increased appetites. They have tremors. You'll see in some people, brittle hair, and you will also sometimes you'll see eyes that are bulging out. Okay, that's a hyperthyroid state. Sometimes that some people may have Graves as well. In hypothyroid state, this is more common, and it tends to be more common in females. Thyroid diseases, and also autoimmunity tends to be more common. Thyroid autoimmunity tends to be more common in females. They're more sensitive to temperature. They tend to have low body temperature. They gain weight easily. They are fatigued. They have brittle nails. They have hair loss. They're constipated because the thyroid hormone just isn't functioning properly. They are depressed. because the mental health is not being managed properly, or the hormones are not being utilized properly. They start losing they start forgetting things like, where did I keep that? Where did I left my phone? Or where were my words? Maybe I'm having it. I don't know. I don't have hypothyroid. Okay, causes of thyroid dysfunction. So if there's a hyperthyroid state, that means your T4 and T3 is high and your TSH is low. It speeds up metabolism, whereas in hypothyroid, low hormones, high signal from the brain. So think of it as like a dial in your brain. When thyroid hormone is too high, it signals the brain like, hey, turn that down. I don't want that. We have enough. When there is a hypofunction of the thyroid, it's not producing. The brain's like, let me turn up the volume. Like, hey, I'm signaling you, make more thyroid hormone. Okay. So then, because, so think of that analogy like a dial. Okay. Oh. So when the thyroid hormone, when the thyroid gland is not functioning properly, this kicks in, increases the thyroid. When thyroid gland is hyperactive, it tells the brain like, hey, lower down the signal. I don't want this much. I'm already producing too much. Okay. In hyperthyroid, you will see most commonly people have Graves' disease. That's it's a common cause, which that means there's an autoimmune attack towards the thyroid, usually TSI, which you can index, you can check through labs. They are nodules on your thyroid. There is some kind of cancer sometimes. There is some kind of inflammation around the thyroid. You're eating too much iodine, or there's too much iodine in the system. Or the patient is taking way too much thyroid medication. That can also, or thyroid hormone, that can also decrease TSH production. Okay. Or they have a cancer of the pituitary gland, which is releasing or not releasing enough TSH. Okay. In Hashimoto's, that is the most common. You will see thyroid autoimmunity. Most people don't even get diagnosed until it's very late in life. I can tell you now, Hashimoto's can start as early as less than 10 years old, but people don't test them unless it's like a severe thing. Infections can turn on autoimmunity. Any kind of damage can turn on autoimmunity. So this is not an old person disease. It just isn't being checked by the medical communities. You have to check your TPO antibodies, TG antibodies, and see if the thyroid hormones are also low. If they are, you're having Hashimoto's. Okay. Sometimes you don't even know why. You have removed your thyroid gland sometimes, right? Or there is radioactive iodine treatments being happening, so medically caused low thyroid hormone. It's because of these. Or you are taking medications. You're deficient in iodine, iodine, which is rare in US, but common worldwide. Just because you see someone has low hypothyroid state, don't just jump and give iodine. Make sure they don't have Hashimoto's, because in some cases, iodine will flare up Hashimoto's. So this is like a very old thought where like, oh, you have thyroid disease, eat seaweed, or here, take iodine. As they have Hashimoto's, you will flare them up. So be very cautious in that manner. Okay. Some people have excess iodine. Okay. Or some people are having pituitary disease where their thyroid stimulating hormone or thyroid regulating hormone has gone down, and which is causing low thyroid production in certain people, or there's severe illness. Again, ICD-10 codes, metabolic syndrome for most people, fatigue caused by thyroid, and other ICD-10 codes. If you do, this one is for hyperthyroid. That's how it's called in medical ICD-10 codes. That's how they describe this. Okay, Hashimoto's, hypothyroid. So these are ICD-10 codes you can use if you know if the patient in fact has hypothyroid or Hashimoto's or hyperthyroid. Otherwise, these codes work great as well in conjunction with these ones. Labs to test fasted. I always like to test my labs fasted. A caution with biotin. Most practitioners don't know this, even MDs may not know this, but if you're supplementing with biotin because your hair is falling out because you have hypothyroid, that will falsely give you a lower thyroid value. So if your patient is on thyroid supplementation, biotin supplementation, or they are taking B complex that has biotin, have them stop for at least 3 days or 72 hours prior to their blood test, so you can have a little bit better picture of your thyroid markers, and they don't report that as falsely low when they do get tested. Okay, so test their thyroid stimulating hormone, primary thyroid hormone, which is T4, T3 free. This is the inactive thyroid. T3 free is the active form of thyroid. T3 uptake is an indirect measurement of T4. TPO antibodies, TG antibodies, thyroglobulin, TSI, you can test TSH receptor antibodies. You can also test for Graves or hyperthyroid diseases. Functional medicine wise, conventional lab, these are the ranges. Functional medicine, there's no functional medicine committee. This is what we somewhat agree on, but this is not conventional medicine. In some cases, if the patient's TSH is like 3.5 and above, I start suspecting autoimmunity, even though this is a large range. An optimal range for thyroid is 1.8 to 3. Okay. So if somebody has high TSH, it's hypo thyroid because you're increasing the volume because the T4 and T3 are low. And when you have low TSH, decreasing the volume because you already have too much. So that's a hyperactive thyroid or hyperthyroidism. Okay. T4 total. If this is the primary thyroid hormone, of course. If it's low, it's a hypothyroid state. High, hypothyroid. T4, of course, these ranges are functional medicine ranges. This is the inactive form. So low, hypo, high, hyperthyroid. T3. Most MDs will not test this. They will say this is where it fluctuates too much. Yes, it does fluctuate a lot. Sometimes not the best measurement, but it helps us know how, in that point in time, how is the conversion of T4 to T3, how it's being utilized. Okay, it's the active form of thyroid. And T3 uptake is the indirect measurement of T4 levels and the amount of thyroid binding globulins. And it helps measure what level of thyroid hormone is bound versus free. I like to test this one because when I'm testing, especially females who may be suspected with PCOS, for example, I'm concerned about, and I'm also testing the testosterone, of course. If this T3 uptake, even though this is the conventional, if this is like high, I start suspecting PCOS in them. And if this is low, in men, for example, we start wondering if they're estrogen dominant. Sometimes they will also have very big belly fat. We call them andropause. And of course, autoimmunity, TPO antibody positive with low thyroid hormone is Hashimoto's. If TPO antibodies are positive, but thyroid hormones are fine, TSH is fine, we call that autoimmune thyroiditis, or stage 1 perhaps of autoimmunities where only the antibodies are high, but we are not seeing symptoms yet. And I've seen this on people. They don't have fatigue or anything. They're fine, but they have attacking their antibodies, maybe because they had Epstein-Barr virus recently or in the past, or they had COVID because COVID reacts mimics TPO antibodies. It also mimics things like different 25 to 25, 20 to 25 tissues of the body. So when the body is coding for COVID or Epstein-Barr virus, it also can sometimes mistakenly code for your own body tissue and start an autoimmune process. Okay. Other thing to note is that wait, where was I? Sometimes you can have latent these viruses can turn on autoimmunity, but they may not have symptoms yet. So just be cautious of that. Sometimes what happens is you may have like an active infection and it will shoot up T4 or TSH. It's just random. So don't freak out. Look at, retest that in like 3-week or 4-week span. If that goes down, most likely the patient was having an infection, their thyroid is fine. Okay. So this I learned from an endocrinologist. She was a very smart endocrinologist, like 5-10 minutes away from my work. I was like, oh my God, you were probably having Graves' disease or something. The endocrinologist is like, no, you're having an infection. And ever since then, I have sent every single thyroid patient to her because she was like, this is an infection, you don't need medication. Whereas somebody else who isn't as invested into their patients, they may be like, oh, here's medication for this. So she was very smart about that. So I appreciate her. And of course, TSI antibodies, TSH receptor antibodies, plus high thyroid hormones. You have Graves' disease, or if only this is high, these are normal autoimmune thyroiditis or autoimmune thyroid storm. Okay. Last slide. Again, emphasis on taking history, doing physical examination, doing palpation of the thyroid gland as well. If your antibodies are extremely high for a patient, send them out for an ultrasound. Tell them, hey, go to your MD, get an ultrasound of your thyroid, because there might be an active destruction of the thyroid or there may be cancer. So if ever the values are too high, refer out for ultrasound of the thyroid. Okay. Perform labs, rule out infections, start with diet and exercise, make sure they have iodine enough in the diet, which is very rare in California, in the United States in general. That's never really the cause. Sometimes you can have injury to the thyroid. Maybe you had something happen, you injured your neck or something, that can make the thyroid function inefficient as well. And that's also a cause of thyroid issues, not necessarily iodine deficiency. So zinc is supported because it supports with signaling from the hypothalamus to pituitary to helps produce TSH hormones and actively engage with the thyroid to start producing hormones. Iron deficiency anemia will decrease the TPO activities, which is thyroid peroxidase, and that can cause hypothyroid state in certain individuals. Okay. And selenium is a cofactor. It helps convert T4 to active thyroid hormone, which is T3. And B complex in general helps with energy and hormone synthesis. Vitamin A helps with TSA secretion. Vitamin D helps with immune modulation. And liver health matters because even though your thyroid is able to convert T4 to T3, it's only about 10%. Most of the conversion of T4 to T3 happens in your liver. So if somebody has fatty liver or any kind of liver disease, their thyroid conversion will not be optimal. So you make sure that they don't have fatty liver, they don't have a liver disease, they have good bile flow, they're digesting their fats properly, they're not burping with fish oils, they don't have fatty stool or floating stool. and they don't have a lot of mucus on their stool. And for certain individuals, you may see that when they eat something very fatty, they may get like stomach cramping because they may actually have bile stones or gallstones or gallbladder sludge in certain individuals, which is not letting the bile flow properly. So sometimes female who have thyroid issues decrease that function as well, and then secondary to that, their bile becomes more stagnant. So we want to make sure everything is flowing, so exercise comes into play. Make sure the patient is eating the essential nutrients and they're exercising, and that bile flow is going. If you're too sedentary, bile flow will also become sedentary. Okay, so make sure that they're not having bile stasis. Autoimmune antibodies are positive. Autoimmune management, lifestyle things. If you know how to do autoimmune management, great. If you don't know, refer them out to somebody who does, because this can be quite complicated. Medication as needed when indicated, and refer out to MD, ND, or specialist and nutritionist as needed. Okay, that ends my talk. I think lastly, I want to say, take care of yourselves if you want to take care of your patients. We as healthcare practitioners are the worst patients. We do not take care of ourselves because sometimes we are like, we know it all, but we do need help as well. If we don't help ourselves, you're not going to be able to help your patient. Like, hey, I'm fatigued. You will not go the extra step. So take the extra step for yourself. Have your friends treat you. Don't be your own doctor. It will not work out. You will not prioritize your health if you become your own doctor. Yes, you know a lot, but you need a healer to heal you as well. So please reach out to your fellow acupuncturists, your other doctors, trade services, or whatever, but get your health in check so you can help the community live a healthier, better life. Thank you. And thank you so much for spending time with me and listening to my first ever presentations to healthcare professionals. I have never done this before, so I hope I did some of you guys justice for spending 2 hours with me.
Thanks, Dr. Bhatti. We are honored to be your first healthcare practitioner presentation. So we do have some questions that came in the Q&A, but one of the questions was from the previous section of your presentation, and that was, what are the optimal ranges for methylmalonic acid?
Go lab ranges for that one. If it's too low, they are not converting their B12 properly because they probably have enzyme deficiency or genetic deficiency that's not allowing it. So if the methylmalonic acid is low, think about that. MTHFR, things like that.
Okay, so as promised, what are the lab companies that you use to test for gut microbiome and all of the other fun stuff that everyone's been asking about?
My gut microbiome, I like GI map is what I'm most comfortable with. That's what I use the most. But I do like, I think Diagnostic Tech or Genova may have like a 3-stool sample one, which I think might be more accurate. I have never used it, but I still get good results with GI map for stool testing. It's not the best lab for bacteria or viruses, but it's definitely good for bacteria, and dysbiosis caused by bacteria. I use Cyrex laboratory array 2, cyrexlabs.com, for my leaky gut testing, which is array 2. That has been phenomenal, hands down the best one. And when you do antibody testing, you must test the patient for the total immunoglobulins, which is IgA, IgG, IgM. If they are too low, you will get false negative on the antibody testing. So say you are suspecting patient has Hashimoto's, but if their immunoglobulins are low, you just wasted money. So through Quest Labs, I use Quest mostly, so that's what I'm talking about. Quest Labs, you do total immunoglobulin serum. It will tell you if you have enough of the IgG, IgM, IgG. If there are enough, that's when I send out patients for Cyrix testing, because Cyrix testing is very expensive.
Cool. So just to tag on to that, in my practice, I do use GI Map, but I also use the Genova Diagnostics complete GI effects panel. It tests like the 4 or 5 pillars of gut health. So if anyone wants to look at that, they can go to Genova Diagnostics. They do have a sample report of all the tests that they run, so you can kind of see what they're testing for, what the markers are. And they do have tutorials on how to interpret that for that reason there. And then we're going back to the iron supplements. Which company do you like? Which ones do you usually
I love Cyrix. Sorry, Apex Energetics. Designs for Health, pure encapsulations. Thorne has some great products, but Apex has Hemi-White that I have seen patient not react to or have nausea, or they're easier to digest. And Ferrosorb, I forget the company name.
So Ferrosorb, I believe, is Thorne, and then Hemi-White is Apex Energetics, correct?
Correct.
Okay.
Yeah, those are the ones that I've seen people not react to or have stomach discomforts afterwards. What type of snacks are good to eat before bed? Healthy fats and protein. Avocados are great. Pistachios are great. Ghee sometimes. Don't go to bed eating a cake. You may have a blood sugar drop in the middle of the night. Or in the middle of the night for those who wake up during nocturnal hypoglycemia. Fats and protein. Prioritize those. Fat is good. Healthy fats are good. Do you recommend testing for HOMA-IR in case of dysglycemia, suspected insulin resistance for pre-diabetics? Yeah, you can. Quest has that. I have not run that test. I think I have probably only run it like very few times, but I don't find that to be necessary. You mentioned coffee. Does this include all caffeine like black tea? That one I will pass on. I'm not 100% sure. Listen to Stacy Sims on YouTube. She is a researcher who focuses on female science, and I think that's very useful. I was just listening to her podcast recently. So look her up, Stacy Sims. I don't know if I have her book around here, but she has a book. I remember the cover with the girl is standing like this. It's a black and white cover with the pink title.
Can you
That's a good
put
book.
her name in the chat, Dr. Batu?
I think I can only message host and panelist, but it's Stacy Sims.
Can you spell it then?
Yep, there you go.
Okay, thank you.
Please put blood sugar test slide that has uric acid on it again, as my device lost internet for a moment there. Okay, let me do that afterwards. Can you please say more on PCOS, what labs values are associated with it? What is the mechanism? PCOS, polycystic ovarian syndrome, very high testosterone, insulin resistance, glucose is too high, liver is not functioning properly sometimes for certain individuals. Some people are just eating way too much sugar. You just put them on proper diet. It will help with hormone regulations. Remember, you need to have fat in order to balance out your conversions, because when you have too much inflammation, you don't convert your hormones properly. So we want to make sure our hormones are getting converted properly. If the TG antibodies are present, but thyroid hormones are normal and they don't have, what do you recommend? If only the antibodies are high, monitor them, make sure they are eating well. I remove them from gluten and dairy because they cross-react with thyroid TPO antibodies, TG antibodies, so that's very inflammatory. So I remove them from those two particular food groups. And vitamin D is necessary. Make sure they have selenium. Make sure they don't have infections, because sometimes you have infections that are attacking leaky gut. Rule that out. Why is there more inflammation when there is a dip in glucose rather than when it's high. It's either high or low, because body's under stress, it's gonna put out signals like, hey, alert, 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 blood sugar is dropping, upregulate everything. So inflammation also goes up because cortisol is going up. Cortisol is an inflammation hormone. Excellent. Dr. Bhatti, this has been very good seminar. The information is insightful and useful. You are so welcome. And let me put that one slide up with the uric acid.
So while Dr. Bhatti is getting back to that slide of uric acid, he is going to make available his slides in PDF form. So once we get that from him, we will email it to everyone that has registered. Also a link for the recording with the passcode to access that. And also remember, you will get an email, but it was also in your confirmation email about how to get your CE certificates for this session. Okay, but if you have any questions, again, you can email us at info@csomaonline.org. I'm going to make Ra get the email, so ra@csomaonline.org. You could email me, but don't do that because I'm busy. Just kidding. You can email me also president@csomaonline.org if you need to, but mostly everything is going to come from info@csomaonline.org. But if you do need anything, just let us know. Any other questions while Dr. Bhatti brings up the uric acid slide?
And one thing, I don't know everything. If I said something incorrectly, feel free to email me and I will try to get back to you. And yeah, that's it. Disclaimers.
It happens.
my
It's
best.
great. We always want feedback, right? This was amazing and so helpful. And it's such a great example of where we have the ability to do this work as licensed acupuncturists, but many of us aren't doing it. We can always move higher up in our scope. We have this gorgeous scope in California. This type of work helps us function at the highest end of our scope. So thank you, Julie, for introducing our community to Dr. Bhatti. Dr. Bhatti, thank you so much for taking your Tuesday night to be the first of our webinar series for this year. We have 3 more coming. So please go to csomaonline.org and look at the other offerings. Plus, join our newsletter if you can. Go to CSOMA Online, join the newsletter. We just sent out an email asking for your feedback for what type of classes you're looking for in our 2026 evening program. We love this community coming together in the evenings. We want to keep it going next year. We're looking to bring a series of 12 unique programs to you, 1 each month in 2026. We would love to hear what you're looking for. What type of education do you want? If you're a CSOMA member, then of course you're, or not, you're able to get credit for these classes, or we make them free for all, just so that the abundance of this great knowledge continues to improve our profession. So please join CSOMA, help us continue to advocate for our amazing profession and for our patients. Please keep coming to our webinars, give us feedback on what you want, feedback for tonight's event, and check your registration email to figure out if you do want to take credit for it and paid for the class, how to do that. If you didn't pay yet, but you want credit for it, you want CEU credit, reach out to us and we can arrange that so that you can get credit for tonight's event. There will be a $250 gift certificate going out to any of the participants that stayed for the class. So we'll be announcing that. We'll do the raffle tomorrow and contact the winner, and you can check our next newsletter for updates on that. So join us in October. We have another event coming up. Thank you, everyone, for being here. Thank you, Dr. Bhatti. Thank you, Dr. Tran, for being CSOMA's president and working so hard for our profession.
You're welcome. Have a good evening, everyone. Tell all your friends about us. But also, if you can, fill out our survey about what you would like to see in the webinar series for 2026. Not only do we ask you for topics or presenters you want to hear from, we also want to know what day and time works best for you so that we can accommodate you, our members. Okay, so give us that feedback. If you don't say anything, we're just going to go with what I want because I'm the president. So yeah, what's going to be convenient for my schedule. So you may not like that. So please put in your feedback so that way we can make sure that we accommodate everyone's schedule so that you can earn these low cost, high value CEs for licensure. With
Dr. Bhatti, we already have a request for you to come back in 2026. So let's talk.
I would be delighted to. I love teaching. When my college shut down, I was very sad. And then Dr. Julie made my dream come true. I did not know I'll be giving seminars so early in my career, but thank you so much for making my dream come true.
You're
'Cause I
very
always wanted to
welcome.
teach.
And I encourage everyone to make friends with our allied professionals, right? Dr. Bhatti and I refer patients to each other a lot of times, and he'll just tell me, hey, I referred a patient to you. They have a crack in their tongue. I'm not exactly sure what that means. Just go treat them. So I get to see the crack in their tongue or whatever else. So make friends. We need our professional allies everywhere. So just do that. And yep, if you didn't get the
And I
email,
think one last
please-
thing, if
yes.
anybody needs help setting up their account with Quest, I'm more than happy to help you. I am aligned with their some organization that helps me get practitioner rates. Say your patient does not have insurance and the test is like $2,000 because you ordered a lot, but when they run my credit card, it's like $200. So that's cash rate. So for certain individuals, if you're not in that program, for example, and it's free for everyone to join, it allows you to get more coverage, or not more coverage, but increased benefits for patients so they save more money when they're ordering lab tests. So I'm gonna
Dr.
help
Bhatti, do you have
anyone.
an email that where people can reach out to you? Do you want to put that in the chat? Do you have an appropriate place, or did
Sure.
you already give that? I'm sorry, and I may have missed that.
I did not. I don't know where to put that. If I type here, will it come to you
You can
guys?
just type it in, and if it only goes to panelists and hosts, then I can go ahead and put that into the chat. So any email that's appropriate for people to reach out to you with feedback or gratitude or questions. Okay,
It's
let me go ahead.
basically drbhatti@drbhatticlinic.com or drbhatti@drbhatticlinic.com.
And hold on, let me just see if I can grab that. Is my cursor letting me grab it?
Do we have any last minute questions, comments? Yep. Carolyn wants to know, do you use a professional co-op? I guess
No,
that's
I
according to your for the labs.
No, I just use Quest Labs because I'm very well integrated into the system. Most of my patients don't have insurance sometimes, or they have PPO, so Quest works really well for them, or I use LabCorp. But if I want to go cash rate, I use Quest Labs. I have done a test that was $5,000 insurance rate, but I only paid $500 for my own blood test. So it dramatically drops the price.
All right, I've retyped your contact information into the chat, so everyone make sure you get that down. And if you don't, it's Dr. Bhatti at drbhatticlinic.com. So that's a good way to remember it. All right, hope to see you all back here in October. Have a good month. Take care of yourselves. That's really good feedback from Dr.
Yes.
Bhatti tonight. We got to take care of ourselves, take care of our patients, take care of your patients, yourself, our community. Thank you for being part of the CSOMA community. Have a good Tuesday night, everyone.
Take care.